Hi, good evening. Hi, good evening. Okay, let's start. Am I audible? Hi, good evening, guys. So let's start. Welcome to the Basics of Cardiac Pharmacology course. And I think we should start that. So hope you are doing well. Yes. Are slides okay? Visible? Quality? Okay, so today we will be continuing our anti-thrombotic agents, what we ended last. We did not go into the deep last class. Right, so this is our second class, guys. I'm Dr. Ajit Singh, and today we are going to discuss especially anti-platelet drugs under antithrombotic. So let's go to the recap what we learned in last class. What we learned in last class. In last class, we were talking about pharmacology, definition of pharmacology, and major branches of pharmacology. So just recap: pharmacology is the relationship between drug and body, and it is showing how the drug reacts to the body and how the body reacts to the drug. So there are multiple branches. One is pharmacokinetics and then dynamics. These are two major branches, and these all are integrated. These all are associated to each other. Correct. So first, when drug comes into the scene after pharmaceutics, manufacturing and formulations, they check the bioavailability and they check the doses in multiple clinical trials. Then they manufacture or formulate the drug to the patients or to the population or to the human race. or then anything, for anyone. So after that, it comes to the human, when they take the medication in any route, any from any route of administration, from oral, from injection, in bolus, infusion, or rectal suppositories, or there are many those route of administrations. So when drug goes to the body, when drug goes inside the body, uh, there are multiple procedures which happens, like absorption, distribution, metabolism, excretion. So this all comes under the branch of pharmacology, which is called pharmacokinetics. And then something is there in the cell when a drug reaches to the cell, and how does it affect on the cell and on the target problem. How does it correct the problem? How does it correct the diseased diseased element inside the body, like cell, or then effect starts from the cell and then it completely goes to the organ in the body. So that receptor interactions and drug receptor interactions, and how drug and receptor, they changes the hemodynamics, and changes the function of the cells. That all comes under pharmacodynamics, right? And this as we have seen in last class, and we have discussed, pharmacology has two major branches: pharmacokinetics and pharmacodynamics. Other coverages of pharmacology are pharmacotherapeutics, where we study about the drugs, their side effects, their dosage forms, their how much we have to give, like dose. And then it comes to toxicology, about the poisoning, about the poisons we discuss, and about the side effects when we give in a higher dose, or when the drug can cause devastating effect, or the a toxic effect. So that all comes under toxicology. Clinical pharmacology is something what we are learning now. Clinical pharmacology is something when it comes to the patient, exactly comes to the patient related things, clinics, right? And pharmacoeconomics is the branch where we discuss about the where we discuss about the money related problem, finances related problems, cost related problems. So cost effectiveness of the therapy, it all comes under pharmacoeconomics. Pharmacogenetics, when we discuss about the genomics and genetic technology, or gene editing, or all the functions, or all the procedures related to genes or human genes, it all comes under the pharmacogenetics. The pharmacognosy, pharmacognosy, what is pharmacognosy? Pharmacognosy is related to something, plants, something about the plants, and plants extract, and how we can use their extracts, and how we can we can formulate the drug from that. How we can formulate the drugs from that, and then we can use inside the human, we can test inside the a body of a human being. And then it comes to the pharmacy practice. Pharmacy practice is another branch of pharmacology, where we really work on the patients, where we usually practice the drugs, where we usually practice the therapeutics, where we usually practice the pharmacology in hospitals, in clinics, in the patients. So that all comes under the pharmacy practice. So these are the major branches and other coverages of pharmacology. Let's go to next slide that we were discussing in last class. Plaque formation. There are three things as we were discussing last. First, because of some toxins, because of the drugs, because of the catheter insertion or anything, there will be some endothelial injury due to any reason, due to hyperlipidemia, or hypertension, adhesive forces, or stress, stresses, or searing stresses, or due to many things, endothelium injury will be there. Endothelial injury means then insider part, insider a part of the vessel, the insider surface of the vessel will get damaged. It gets damaged by any method, or any procedure, or by any element, like toxins, foreign particles, fat accumulation, or catheter insertion, or any other surgery in any other part of the body. So some foreign particles flow into the body, and flow in the circulation of the body, through the blood, it comes to the cardiac uh, cells, and it creates some injury, it develops some injury. So after injury, at the injury site, there are so many factors which gets which get excreted. These factors are like one Willebrand factor, WF, and then we have collagens, and then we have other factors, tissue factors, which gets secreted from the injury site, and they activate the platelet. They start the coagulation cascade. They start the other process which can lead to form our plaque at the end. So in last class we have discussed about platelet adhesion, platelet activation, and platelet aggregation. Like at the injury site, injury happened, then some platelets, platelet activating factors came out, like when one Willebrand factor or collagens. So collagens actually start this activation, and then when platelet gets activated, platelets get activated, they call other platelets to bind to that, and start making plaque. And then parallelly, tissue factors start the coagulation cascade. So all the coagulation factors, they are in the dormant state, they are in the inactive state. But when tissue injury happens, after the tissue factor gets secreted, or tissue factors comes out from the injury site, or from the uh, surface of endothelium, then it activates the coagulation factors, and parallelly coagulation cascade also gets started. And these two procedures, or these two we can say cascades, platelet cascade and coagulation cascade, end up making a thrombus, end up making a plaque, right? End up making a plaque by so many factors. Correct. So that we have discussed in last class. Let's repeat once more the ADP and ATP thromboxane formula. So what happens when one Willebrand factor comes out? It attracts some platelets, and it attaches to the platelet surface, where one Willebrand factor receptor will be there. One Willebrand factor receptor will be there. So these factors, this VWF will attach to that, and it attracts some other platelets to towards this activated platelets. Then other platelets will get activated. Then some collagen gets activated. Collagen comes out, and then it activates the tissue factors, and that those tissue factors will activate our coagulation cascade. So after coagulation cascade, the end product of coagulation cascade is fibrin. So that fibrin comes into the plaque, which is made up of platelets, which is made up of platelet. As we can follow the cursor here, it then it starts binding. It starts tighten the plaque. The fibrin is the end product of coagulation cascade. It start binding this plaque, and make it solid kind of thing, right? Now, so this was the platelet cascade. Now we will go to the coagulation cascade, as we were discussing in last class. Coagulation cascade, it might look very tough. It may confuse you, but I'll make it very simple for you guys. Very, very simple for you right now. It is very simple. So there are two how it activates and how it works, and how it lead to your end product, which is fibrin. So we'll be talking about that, and you try to understand that. It is very, very easy. There is nothing to understand in that. So there are two pathways. One is extrinsic pathway, and one is intrinsic pathway. Intrinsic pathway and extrinsic pathway. So this intrinsic pathway starts with the collagen. The intrinsic pathway starts with the collagen, which comes out at the damaged surface, which comes out at the damaged surface. Damaged surface means injured wall, or at the injury site. The collagen comes out. This collagen will activate the inactivated or dormant coagulation factor. Okay, the coagulation factor is X2, means 12, factor 12. So this factor 12, will be activated into the form, X2A or 12th A. So this is very simple. Just try to understand these two things. Intrinsic pathway will get starts by collagen. That collagen will be excreted from the injured site, from the site of injury in the epithelium, okay, to make the plaque. So this collagen will activate the inactivated or dormant 12 factor, coagulation factor 12, right? And in the extrinsic pathway, what happens? In the extrinsic pathway, there are some other tissue factors which comes out. Those tissue factors, will activate the factor 7. So always remember, all the factors in all the factors in this coagulation cascade are inactivated, right? All the factors are in this pathway are inactivated. These are just activated by some other external elements like collagen or the tissue factor. Okay, so how it works? Remember two things, 12 and 7. So in extrinsic pathway, you need not to do anything. You need not to do anything. It is just like that, some injury happens, trauma happens, some tissue factors will come out, and these tissue factors will activate 7 into 7A. 7 into 7A. In intrinsic factor, collagen is the main responsible, responsible factor or responsible element which activates 12 into 12A. So A is nothing. A is here activated form, right? 7 to 7A, 12 to 12A. Got it? So now let's crack it one by one. In intrinsic pathway, 12 will convert into 12A, then 12A activated form will convert 11 into 11A. Okay, 12, 11, no 10, 9. No 10, 9 will come here before 10. 12, 11, 9, 10. These are the four things. Remember, 12, 11, 9, 10. So this 10 will come after 9 here. This is the procedure to remember. 12, 11, 9, 10. So 12 will activate. So 12 is activated by collagen. Now 12 will be activated into active form 12A. This 12A will activate 11 into 11A. Correct? So 11A is nothing but activated form. So now this activated form will convert 9 into 9A. Then this 9A will convert convert 10 into 10A. Got it? 12, 11, 9, 10. Done. In extrinsic, there is nothing. Extrinsic only 7. By the tissue factors, at the trauma site, at the injury site, 7 will convert into 7A, and then 7 will convert again, X 10 into 10A. So this 10 here is the major factor. This 10 is the major factor here at this site, right? This 10 is the major factor which actually takes part, in the conversion of prothrombin into thrombin. Okay, so at the end product in the coagulation cascade, we need fibrin. We need fibrin, which creates the fibrin clot with platelets and other extrinsic matters, or other fat matters, or other dead RBCs, other platelets, and calcium particles. So it combines everyone into a cross-linked mass. This fibrin creates the cross-linked mass, and it tightens the plaque. Right, it tighten the plaque. Understand? So now come back to that. 12, 11, 9, 10, and then 10 will convert prothrombin into thrombin. So this prothrombin is nothing but factor 2, right? Coagulation factor 2 is prothrombin. This prothrombin will get converted by maybe factor 10 or maybe factor 5. So how does this factor 5 came into the scene? In the other site, other than the intrinsic and extrinsic pathway, there are something, proteinase pathways. There are some other proteinase pathways. So these proteinase pathways, what they actually do in this coagulation cascade. So this protein C is again a thrombomodulin kind of factor. This is also a factor, thrombomodulin. So it gets activated by surface proteins. Protein S is nothing but surface protein. As you can see here with my cursor, you check out with my cursor. Here this protein S is nothing but proteins, surface protein, right? Surface protein. So this surface protein also comes out at the injured site. This protein surface or protein S activates the protein C into active protein C. So everything is everything is in inactive form or dormant form. They're just enjoying at inside your circulation maybe, or they're just enjoying inside, we can say in the layman language, like they're inside your lumen of the vessel, right? Once it gets injured, they all are in the active form by different particles, by different coagulating factors, or different extrinsic, or we can say different foreign particles like collagen or tissue factor, or surface proteins. So this protein C also gets converted into active form, and this protein C activates the coagulation factor 5. Coagulation factor 5. So this 5 will activate it into 5A, and then here, remember guys, prothrombin is converted into thrombin, or factor 2 is converted into 2A by two factors, that is 5 and 10. It is easy to remember, 5 into 2, 10. Two factors, 5 and 10. Got it? Here, look at my cursor. 5 and 10. 5 and 10. Right? So this prothrombin or factor 2 is converted into thrombin or activated form of factor 2, 2A, by 5, and 5 into 2, 10. So remember, 5 is converting 2 into, 5 and 10 are converting 2 into 2A. So it is easy to remember, 5 into 10, 5 into 2 is equal to 10. Correct? So 5 and 10 both are converting 2 into the activated form, or we can say in another form, 5 and 10 are activating 2 into 2A. Got it? So 5 came from the surface protein side. This 10 came from the extrinsic and intrinsic pathways. Correct? In the parallel side, in the other side, if we look at the origin of extrinsic and intrinsic pathway, intrinsic by collagen, extrinsic by tissue factor. Got it? I think picture is clear now. Picture is very clear. Right. So now we came to the factor 2 and 2A. So by 10 and 5, this prothrombin converted into thrombin. Now this 2A, or we call thrombin, this thrombin will convert factor 1 into 1A. It is a opposite process, ulta process. Like it is coming from the upper side. It is coming from the 12, and it is coming to the 1. Correct? Got my point? It is coming from the 12, it started from the 12 and coming to the 1. So this 2A converts fibrinogen into fibrin. Fibrinogen is nothing but factor A, and fibrin is nothing but factor 1 and factor 1A, right? So this factor 1 is very important, because this is only making the mess by cross-linking all the by cross-linking over all the other particles, other calcium particles, dead RBCs, or alive RBCs, or WBCs, or platelets, and fat particles. Now when the plaque gets started, so many particles will come and stuck into that plaque. So it gets develop it starts developing, and it goes more and more. Maybe as I told that day, it will be sudden, it will be quick, or it will be delayed, or it will be slow. It depends. depends on how big is the injury, and how quick these coagulation cascades and cascade works. Got my point? So now I think we are clear in the coagulation cascade. Yes, we are clear in the coagulation cascade. Now, as I was telling, very simple way. In the very simple way, as you see, as you can see here, uh, intrinsic pathway from the collagen, 12, 11, 9, 10, and then intrinsic pathway 7, sorry, 12, 11, 9, 10, yes, and then extrinsic pathway from 7 to 10, and then 10, convert 2 to 2A, and 2A converts, 1 into 1A, right? Now, what are the factors name? These all factors have different names. You know, as we can see here, factor 1, 2, 3, 4, 5, 6, 7, 8, 9, 12, 13. These are different, but actually these have some names. You know, so factor 1, as we were telling, is fibrinogen, and activated form is fibrin. 2 is prothrombin, and activated form is thrombin. Okay, as factor 3, it is thromboplastin, or we can say tissue factor, which is activating which is activating uh, factor 7. Got it? So this thromboplastin or tissue factor is activating factor 7 in the extrinsic pathway. Origin of the extrinsic pathway, tissue factor is activating factor 7. Okay, so after factor 3, these are the important factors here. Factor 5, factor 5 is pro-acceleratin or labile factor. You know that there are only two factors, remember, 5 and 10, which can convert factor 2 into 2A. Got it? So factor 4 here is nothing but calcium ions. Factor 4 is calcium ions. In the coagulation cascade, if the calcium channels, or sorry, calcium ions are participating, that means there is calcium ions are named for some factor, because this is coagulation cascade. So every factor has some name. So calcium ions, got the name as coagulating factor 4, right? So coagulation factor 4 is calcium ions. But here, coagulation factor 5, which is pro-acceleratin or labile factor. Why we are calling it labile factor? Because it is, you know, having a very key role here, because it is converting something very important. It's has some labile kind of role here. It is converting prothrombin into thrombin, which is going to convert fibrinogen into fibrin, and it is almost the end end product of the coagulation cascade. This is very important. And why prothrombin is very important, why not fibrinogen or fibrin? Because fibrinogen is the end product, and if all the drugs coagulating, anticoagulants, all the anticoagulants, they work before the prothrombin only, or on the prothrombin only. you know all the coagulation anticoagulant drugs, they work on this step only, the conversion of prothrombin into thrombin. They prevent this only, they prevent this process only. They prevent the activation of prothrombin into thrombin only. That's why we give more importance to the prothrombin. Got it? Now, uh, factor 7, which was activated by factor uh, 3, or tissue factor. So factor 7 is pro-convertin or stable factor. Pro-convertin means why? Because it is the first factor which gets converted by the tissue factor, or factor 3, which was secreted from the injured site, right? So that's why we call it pro-convertin factor or stable factor. And then we come to the factor 8. Factor 8 is anti-hemophilic A factor that actually does not take much part into the coagulation cascade. In the coagulation cascade in plaque formation, anti-hemophilic A factor is actually takes part in hemophilic patients in the other sense, in the other procedures, right? Now here, factor 9. Factor 9 was also important because it was activating factor 10. and factor 10 is like activating prothrombin into thrombin. So this factor 9 has some name, which is like anti-hemophilic B or Christmas factor, or PTC, prothrombin targeting uh, you know uh, prothrombin targeting capsule, or we can say like yeah, prothrombin targeting capsules, right? Okay, so then factor X, which is very important, factor X. Why X is important? Because it is converting thrombin into, sorry, prothrombin into thrombin. So this PTC is, as I was telling, this factor 9, anti-hemophilic B, but it also, takes a major part in our coagulation cascade, and it's convert Stuart or Stuart-Prover factor, factor 10 into, 10A, right? So this factor 9A PTC is, plasma plasma thromboplastin components. PTC is plasma thromboplastin components, PTC. Okay. So remember, PTC is plasma thromboplastin components. Okay, then now we'll come to the Stuart or Stuart-Prover factor, factor 10. Factor 10 is very important because it is converting prothrombin into thrombin. Then factor 11. Factor 11 is plasma thromboplastin antecedent. So this doesn't take even much part in coagulation cascade, because that work comes like 12, 11, 9, 10. 12, 11, 9, 10. So it is a mediator factor which actually takes part to convert PTC or anti-hemophilic B into the activated form. Then factor 12, which is the origination of intrinsic factor, intrinsic pathway in coagulation cascade, factor 12. So it is called Hagman factor or contact factor. Why it is contact factor? Because this is the starting, or this is the contact, this is the actually contact factor in the coagulation cascade in the intrinsic pathway. So collagen comes and contact this Hagman factor or factor 12, right? And then it gets activated into activated form 12A, and then 12A converts 11 into 11A, then 11 converts 9 into 9A, then 9 converts 10 into 10A. Correct? So that process starts with the contact. So there is something called contact person. So this as we have everywhere the contact persons. So in the intrinsic pathway, our factor 12 is the contact person, is the contact factor. Got it? Remember it. It is the contact factor. And then factor 13. Factor 13 is fibrin stabilizing factor. It actually works at the very end. Works at the very end with factor, factor 1. Factor 1 is fibrinogen, right? Which converts into fibrin 1 into 1A. So this factor 13 works there. This factor 13 works there. It stabilizes the fibrin. It doesn't activate, but it stabilizes the fibrin into creating mass, to tighten the plaque. you know when it comes to tighten the plaque, so it stabilizes the fibrin there in the plaque, and it helps in creating giving strengthen to this plaque, or we can say our whatever the thrombus, right? So I think you are clear with the factors also. Now I'll just want to show you a very simple video. You will understand this now very quickly. You will understand everything about what we are talking for last class and today. So I'll just start. Hope you will get the voice also. Yeah. Now very quickly, you will understand everything about.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor.
I'm sorry, what happened? Wait.
And von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules, such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. The clot grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation in a continuous feedback loop. Additionally, thrombin induces the formation of fibrin for the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
Okay, so this video was from the Bayer International, made by Bayer International. It's a very beautiful video where you can look at all the full process of plaque formation, how this platelet comes and gets activated, and get activated and make the plaque and activate other factors as well. So here in the questions in YouTube, I can see that platelet factor 6 is not there. Why it's not there? See, platelet factor 6 is there, but it is not directly participating in coagulation factor, because when platelet 6 is actually the generation of platelet 5, platelet factor 5. Platelet factor, sorry, not platelet factor, I'm very sorry. Coagulation factor 6 is generating coagulation factor 5. So only this coagulation factor 6 is converting into coagulation factor 5 later. You know, that's how the coagulation factor 5 generates, or originates. So it originates from the coagulation factor 6 only. So 6 is not participating directly in the coagulation cascade, right? It is generating, it is making the coagulation factor 5. So that's why we do not mention coagulation factor 6 in coagulation cascade, because we have coagulation 5, which is the we can say what we say is the generated product, or product of coagulation factor 6. So we can say coagulation factor 5 is the product of coagulation factor 6. That's why we do not mention 6 and we mention only 5. Got it? I think you are you got the answer. Then now we will come to the anti-thrombotic drugs. As we were discussing, there are three drugs category. One is antiplatelets, one is fibrinolytics, one is anticoagulants. So let's go one by one. Fibrinolytics. Fibrinolytics are the drugs which usually work to dissolve the existing thrombus, and these are just for the acute treatment of thrombus, or acute treatment of the plaque, or in case of acute myocardial infarction, in case of acute ischemic stroke, in case of massive pulmonary embolism, in case of we can say acute PVD, or deep vein thrombosis, acute deep vein thrombosis, or peripheral vascular disease. We dissolve the clot, by fibrinolytics. So these fibrinolytics are only used in the acute cases. That's why we call them as an acute treatment, because they dissolve the clot, because they dissolve the fibrin, they dissolve the fibrin, and then all the factors gets free. All the factors get free out of this plaque, and it came out of the plaque, and plaque dissolve, and the situation gets normal there, right? These are about the fibrinolytics. Then the next is antiplatelet drugs. Antiplatelet drugs are actually not for the treatment. These are actually for the prevention. These are actually working as prophylactic drugs. Antiplatelet drugs are actually prophylactic drugs which prevent the event, which prevent the formation of plaque. These are not directly working on the plaque, these are not directly deactivating the plaque, or these are not participating in dissolving the plaque. In many cases, like when the patient is on patient is there with so many risk factors like smoking, diabetes, hypertension. in that cases in that cases sometimes with the old age and with some problems, so in that case we give antiplatelet drugs as a prophylactic to prevent the cardiac events. Correct. We give antiplatelet drugs as prophylactic, right? And then what happens if the patient comes with the acute coronary syndrome, or the patient is already having CAD, coronary artery disease, or if the patient is having acute stroke, or if the patient is having the history of stroke, then we start our antiplatelet drugs to prevent the future events or to prevent the recurrence of the event. Correct. In that case, we use them as a prophylactic treatment, not exactly which can stop the clot, or which can directly dissolve the clot, right? So these are the long term therapy. And after PTCA also, when we put stent into any a patient with the acute MI, or with the cardiovascular diseases, or in the stroke patients, or after bypass surgery, we give antiplatelet drugs for certain time, like for 1 year or 2 years, or for sometimes based on the condition for lifelong. In that case, these are just to stop or just to prevent the future events or the recurrence of the disease. Correct. That's why these are called as secondary prevention, or secondary prevention. Has we can see here, secondary prevention, antiplatelets are secondary prevention, fibrinolytics are acute treatment, and anticoagulants are primary prevention. Why? Because anticoagulants are working in the prevention and treatment of thrombosis in both venous and arterial systems. Anticoagulants are we usually use as prophylactic also, and to prevent the plaque also, and to get it worse, to get the condition worse in case of atrial fibrillation, in case of stroke, or sometimes in case of acute MI also we give. But nowadays we do not give anticoagulants in case of MI. So these anticoagulants are given usually in the recent era for the any surgeries, valvular surgeries, or valve replacement, right? In case of atrial fibrillation, to stop any unwanted effect kind of thing like stroke or MI. Correct. So these are primary prevention. Antiplatelets are secondary prevention. Fibrinolytics are acute treatment. Remember. So now comes to antiplatelet agents. These drugs are used to stop the clot formation, right? By inhibiting platelet activation and adhesion and aggregation. As I told you, platelet cascade is nothing but where the platelets get activated. They the adhesion property, and then to each other, and then they aggregate and make a plaque, or they form a plaque. Correct. So this is antiplatelet agent. So what are the conditions, or what are the indications where we need APAs, antiplatelet agents? So it might be acute ischemic events, maybe myocardial infarction, or maybe cerebral ischemia, or it would be maybe we are giving as a secondary prevention of coronary artery disease, where PTCA or stenting already done, right? So in that case also we need as a secondary prevention antiplatelet agents. Then in case of angina means when there is no obvious myocardial infarction, but there are some ECG changes which can lead to MI, or which can lead to the ischemic events in future, in that case also we give antiplatelet drugs to prevent the future events. And then stroke or transient ischemic attacks, definitely clopidogrel is the preferable drug to give in TIAs or stroke, but of course clopidogrel is also antiplatelet agents. So it is and clopidogrel is more effective over aspirin in case of stroke, right? That we will read later. So these are the indications for antiplatelet drugs. Then the peripheral vascular disease. Peripheral vascular disease means what? Peripheral vascular disease means it might be deep vein thrombosis. It may be some PAD, peripheral arterial disease, where your arteries get blocked by the plaque or by the thrombus in your lower limbs or upper limbs. Lower limbs means your legs. Your upper limbs means your hands, or maybe sometimes your upper hand or lower hands, or deep deep vein thrombosis in that case. So in that case also we need antiplatelets for some time. And then the another prevention and another indication which is very important for antiplatelet drugs use, that is atrial fibrillation. In atrial fibrillation, what we do, why we give antiplatelet drugs, because atrial fibrillation is a problem with the conduction, with the conduction of heart, so it is the abnormal beats. So due to this abnormal conduction in the heart, there are the chances of sudden heart attack, there are the chances of sudden myocardial infarction, there are the chances of sudden clot formation, there are the chances of sudden cerebral ischemia which can lead to stroke, correct? Right, which can lead to cardiac arrest even. So in that case we continue our antiplatelet drugs to the patients. Got it? And then here is the classification of antiplatelet drugs. Antiplatelet drugs, there is only one drug in which is which we give with every drug in case of acute MI, or in case of prevention, that is aspirin. Aspirin is Cox inhibitors, Cox inhibitor. Cox is nothing but coxygenase enzyme. So this aspirin stops the coxygenase enzyme, or it inhibits the activation of coxygenase enzyme, and it stops the process there only. And it's stops the process of platelet activation by stopping coxygenase enzyme. Then the second category is P2 white cell inhibitor, or ADP inhibitors, ADP conversion inhibitors. So ADP antagonists also we call them, P2 white cell receptor blockers or ADP antagonists. These ADP antagonists are nothing but clopidogrel, ticagrelor, or prasugrel. So clopidogrel and prasugrel are the older drugs, and now the recently they have launched the reversible effect, the drugs with reversible effect. Clopidogrel and prasugrel does not have reversible effect with on platelets, but the newer drugs called ticagrelor and cangrelor is not yet in the market in India at least, but ticagrelor is there in the market for last 2 to 3 years or 4 years, and it is very much effective and very much a good drug over the clopidogrel and prasugrel, right? So in that case what happens, uh, because as we have seen in that chart of plaque formation, the ADP converts into ATP, right? ADP converts into ATP, and ATP activates the platelet factor 3. The PF3, platelet factor 3, activates the von Willebrand factor, and von Willebrand factor actually attract the platelets to come and join and aggregate. That was the process of platelet aggregation. From at the site of injury, there were some factors where because of them ADP converted into ATP that activates platelet factor 3, and that platelet factor activates von Willebrand factor VWF, and that VWF attracts to the platelets, the inactive platelets, that active the platelets in the circulation, and catch them to the injury site, and then it activates other platelets and aggregate them to make a plaque. So these ADP antagonists, they just stop the conversion of ADP into ATP, right? Or AMP into ADP. AMP into ADP or ADP into ATP. So they stops the conversion or activation of ADP only. That's why we call them ADP antagonists. All are ADP antagonists: clopidogrel, prasugrel, ticagrelor, right? And this receptor, the receptor type is P2Y12. So these get attached to the P2Y12 receptor and blocks that process, blocks the conversion of ADP. That's why there are two names. We can call them P2Y12 receptor inhibitors, or we can call them ADP antagonists, ADP inhibitors, ADP conversion inhibitors, right? Then there is the third category. There's a third category which is called as glycoprotein 2b3a inhibitors, GP2b3a inhibitors. These drugs are not available in the oral format or oral doses form. These drugs are actually given for the acute treatment, or given when we are giving during the procedures of PTCA, or when we need the acute stoppage or acute prevention of massive platelet aggregation, when there is a chances of there are the huge chances of platelet aggregation or platelet activation. In that case we use these GP2b3a inhibitors. I'll give you an example. Like when the patient comes to the hospital with MI, myocardial infarction, and we started on antiplatelet drugs, dual antiplatelet therapy, aspirin with any P2Y12 inhibitor or any ADP antagonist, like aspirin with clopidogrel, or aspirin with prasugrel, or aspirin with ticagrelor. Correct. After that, what happens? The patient is evaluated by ECG, by echo, by other biomarkers, maybe troponin T, or maybe CKMB, or maybe NT-proBNP. So all the tests are done. Now patient has undergone the angiogram, which is CAG. So after CAG, what we came to know that there are two blocks, right? So now we have to remove the blocks. How? Maybe by the procedure of PTCA or PCI. PTCA is percutaneous transluminal coronary angioplasty, or PCI is same thing. PCI is same thing, like percutaneous coronary angioplasty or intervention. PCI is intervention. Like, so we went we got the patient to the table to do that PTCA procedure, right? To remove the block, or maybe we are putting the stent, to prevent the further future events. So in that case, when we insert the catheter, because this PTC and all are done by the catheters, right? These all are done by the wires and catheters. What we insert into the human body, what we insert into the coronary artery through the different access, like radial access or brachial access, or maybe nowadays we are not using brachial access, but maybe radial access or femoral access. So when we insert the wire, when we insert the catheter, there are the high chances of further injuries inside the coronary arteries, and there are the high chances of plaque formations during procedure, right? So at that time we need something, some drugs which can stop that platelet aggregation at that time during the procedure. So we give intravenous GP2B3A inhibitors. In that case, these are for short time, but these are quick, and these drugs are given during the procedures to impact on the huge platelet aggregation. Right? These are not given for the long terms. These are not given for like 5 days or 10 days. These are just a short-term process, short-term drugs. We give like one shot or two shots. That's all, not more than that. And these are very expensive as well, right? GP2B3 inhibitors. So the drugs in that category are abciximab, aptifevatide, and tirofiban. Right? You may have heard of these drugs when you might be posted in cardiology department. So these all are antiplatelet drugs. Then there is something phosphodiesterase inhibitors. Phosphodiesterase inhibitors are not exactly in use now, not being used, and but of course you should know that there is something which stops or which inhibits the phosphodiesterase. That is not actually the important factor, because it takes part like 5 to 10% in the clot formation, but still we do not focus on that because the major part is covered by Cox inhibitors and P2Y12 receptor blockers. right? The example of phosphodiesterase inhibitor is dipyridamole or silagestol. Then what are the mechanism of actions directly? If we can see, we have seen in the last, or while reading these things, the classification, of course we got to know about the mechanism, but still, see, antiplatelet drugs are these are known as anti-aggregants because these stops or these prevents the platelet aggregation, right? So these drugs decrease the platelet aggregation and inhibit the thrombus formation. Correct, you got to know this. Simple. Antiplatelet drugs are effective in the atrial circulation, and these are widely deployed in the prevention of thrombotic, cardiovascular, and cerebrovascular disease. Cardiovascular, MI, maybe CAD, other CADs, and then cerebrovascular means TIA, and stroke. Correct. So Cox inhibitors is aspirin. It irreversibly inhibit coxygenase 1. So irreversibly means what? I'll give you an example and I will explain why this is irreversible and reversible. Because in ADP antagonists, clopidogrel and prasugrel, they work as reversibly, and ticagrelor works as reversibly. So when the injury happens, when the injury happens in the endothelium of our cardio vessel, which is called as coronary artery, when the injury happens inside the coronary artery, and the inner wall, which is called endothelium gets injured, right? So at the injury site, the platelet comes and start getting aggregated. So while platelet gets start platelets get aggregated, and there are certain factor, von Willebrand factor, or there are certain platelet receptors. So, and then another factor is COX1. So in coxinase 1, or we can say ADP inhibitors, what happens? These all receptors are available on the platelets surface. Remember, these all receptors are available on the platelet surface, and which makes other platelets more prone to come and join that platelet, to get activated, to get aggregated. Correct. So after aggregation only they make plaque, right? So why irreversible and reversible? So like when aspirin goes to the platelet, activated platelet, it binds to the platelet site, right? Sorry, binds to the platelet receptors. Certain receptors like aspirin will bind to the coxygenase receptor, or clopidogrel will bind to the ADP receptors, or not ADP receptors exactly, P2 white 12 receptors, or prasugrel ticagrelor will bind to the P2 white 12 inhibitor receptors, or GP2 B 3A receptors antagonist will bind to the glycoprotein 2B or 3A receptors, right? So these aspirin, clopidogrel, and prasugrel, when they bind to the receptors, they bind permanently. Remember these things, irreversible and reversible. They bind permanently. If they bind once, these drugs molecule bind once to the receptor, it is like permanent, and it will end with the death of platelet. It will end with the death of platelet. It will not detach before the death of platelet. So this is a irreversible process. Once it is attached to the platelet, that means this platelet surface is completely occupied by the drug. This will not detach, and there is no vacancy, or there is no place for the other platelets or other foreign particles or other activated von Willebrand factor or other Cox to get place on the platelet surface. So this is irreversible procedure. That means if the aspirin is attached to the platelet, that means it will end with the platelet life. But ticagrelor has some good efficacy, and has some good advantage. That's why it is a new drug. It is of course expensive, but it is very new drug, and overcome multiple problems which were happened with clopidogrel or prasugrel. So ticagrelor, what happens? Ticagrelor binds to that P2 white 12 receptor at the surface of platelet. It binds to the surface, and it detach once its a T half gets over, or once the the drugs components life gets over. T half gets over after some time, like it binds like from 7 hours to 24 hours. After that it detaches. ticagrelor components detaches from the platelet, and the platelets are again happy, and they are circulating, and they are functioning well as we need in our circulation, because platelets has a very important role very important role in our body to get aggregated, not only in the plaque formation, but platelets have the role when we get our physical injury. Platelets are coming there, platelets are aggregating there and making the stopping the bleeding. Correct. So in aspirin and clopidogrel case, the bleeding will be there are the chances of high bleeding if we get injured somewhere, maybe inside the body, inside the colon, or inside the a GI tract, or maybe outside. When you get physically injured, that will take much more time to stop your bleeding, because these all platelets are occupied by the drug components, like aspirin or clopidogrel or prasugrel. But in case of ticagrelor, what happens after 24 hours, or after certain time, after certain period, when this ticagrelor drug gets over, the activated form gets over, that time platelets are again active and again ready to mingle with other platelets at the maybe inside the body injury site, or maybe at the physical injury site. So in that case you will get a good chance of healing. You will get a good chance, or you will get more platelets to get bind, to get to aggregate at the site of your injury, and stop bleeding. So, and that is the advantage with ticagrelor. Ticagrelor has reversible effect, and other drugs do not have any do not have any reversible effect. Like all the drugs, like aspirin, clopidogrel, prasugrel, even the glycoprotein 2b3a inhibitors, abciximab and tyrofibin are same like clopidogrel and prasugrel. Only eptifibatide has the similar effect like ticagrelor. Like similar effect means a reversible effect. you know this ft also binds reversibly to the platelet receptors, platelet surface, and the concerned receptor. Got it? So I think I'm clear there about mechanism of action and reversible and irreversible process. Okay, then go to the next slide. So here we can see all the mechanism of action in one shot. Here, let's look at here. Plate plaque disruption or plate injury site. Tissue factors, collagens activation, and von Willebrand factor activation. So now we'll come directly to the platelet adhesion and secretion. So before platelet aggregation, when the collagen and von Willebrand factor comes, these activates the Cox or coxygenase 1. Coxygenase 1 is enzyme, of course protein, but it's enzyme, right? So aspirin stops the conversion or stops the activation of COX1. So this process, as you can follow my cursor here, this will stop the conversion of coxygenase 1. Got it? Here is the work of aspirin. In the other hand, in the same, after activating platelet adhesion and platelet secretion, there is the conversion before platelet factor 3. Remember, before platelet factor 3, because ADP is converting platelet, ADP is activating platelet factor 3, which is the most responsible factor to activate the platelets or to attract the other platelets to bind, right? So clopidogrel and ticagrelor and prasugrel, because these are ADP antagonists, so these stops the conversion of ADP here, right? Aspirin is stopping conversion of coxygenase enzyme, and ticagrelor clopidogrel stops the conversion of ADP. And then it comes to the other factors, like then coagulation cascade parallelly works. Now all the platelets are activated. Then what happens after platelet activation? See, in that platelet activated, but when platelet gets activated, this GP2B and 3A inhibitors, the drugs which are actually given in bolus, or maybe inject, these are injectable drugs in the when we need a huge response and quick response to stop the aggregation. So when the platelet gets activated, we give these drugs, and also these also bind to the surface of the platelets, all the receptors, all the GP2B3A receptors, and stops the aggregation. when these drugs bind to the surface of this platelets, these occupied all the surface, and these stops the mingling or the aggregating aggregation process with other platelets, right? So got it. This is the simple and very important mechanism of action of antiplatelet drugs. These are very important because in the world, we know cardiovascular diseases are at the peak, at the highest point, and these all we need to know how the platelet agents, antiplatelet agent works, because I think at every home, every house, there is one patient with cardiac diseases, and everyone is taking aspirin or clopidogrel or these things. So we also know this is that's why we have conducted this basics of cardiac pharmacology. Okay, now let's talk about aspirin something. So aspirin is most widely used antiplatelet agent worldwide, right? So the most widely used. I'll give you a simple example. Aspirin is like potato, right? Aspirin is like potato in our vegetables. We can use aspirin, or this sometimes must. We have to use aspirin with clopidogrel. We can use aspirin with the ticagrelor. We can use aspirin alone. We can use aspirin with our other coagulation anticoagulants, right? And we use sometimes aspirin with our thrombolytics, because thrombolytics are for quick treatment and aspirin is for the prevention. So aspirin is like potato, we can use anywhere with anything, and it is sometimes must use, right? It has the analgesic, anti-inflammatory, and antipyretic effect also, right? Aspirin is not only for the antiplatelet functionality. We can use, or we usually use dispirin for the pain reliever, analgesic, right? We use aspirin as a pain reliever also, dispirin we use, correct? And then aspirin is also work as anti-inflammatory. In case of rheumatic heart disease, we give very high dose of aspirin, very very high dose of aspirin. So in that case, we need to give aspirin. This is anti-inflammatory drug as well. Okay, so as we have discussed, aspirin blocks the production of thromboxane A2 by accelerating a serine residue near to active site of platelet cyclooxygenase COX-1, and then action of aspirin on platelet COX-1 is permanent and lasting with the life of platelet 7 to 10 days. It is not irreversible, it is reversible. Got it? Then complete inactivation of platelet COX-1 is achieved with a daily dose of 75 mg. We usually give 75 mg, but before giving, there are two doses with antiplatelet drugs, guys. There are two doses. One is loading dose, one is maintenance dose. Loading dose means when we need the quick compression or quick suppression of antiplatelets, we give a loading dose, and then we start with a low dose to maintain that suppression, right? To maintain that inhibition, to maintain that aggregation, stoppage, or the prevention. So platelets, this aspirin's loading dose is 325 mg, or right, 325 mg we give as a loading dose. Then uh, what's there? Then maintenance dose could be 75 mg or 150 mg. In case of, it depends, like if the patient is at a higher risk of bleeding, we give only 75. If the patient is tolerating well and patient is having high chances of recurrence of cardiac events, or stroke events or TIA events, then we give 150 mg per day. So if you think higher the dose, more the efficacy, not at all with aspirin, because higher dose can lead to toxicity, especially bleeding, right? In case of aspirin, so we have to maintain with a good dose. Good dose is like 75 mg, and if we increase the dose just to check the efficacy, or if we think like it is more potent, if we are giving high dose, not at all. High dose can land up the patient into trouble of bleedings, you know so as I was talking, when rapid platelet inhibition is required, dose we can use at 150 mg per day. And in rheumatic heart disease, the another indication, we need 3 to 4 grams per day. And to show the NSAIDs effect. But rheumatic heart disease is like in the kids, or in the adolescents, young adults, we give that aspirin. So in that cases, we do not have much chances of bleeding. We have, of course, but we do not have as we have in our elderly patients or patients with the cardiac events. So the major side effects of aspirin is dyspepsia and erosive gastritis, and then peptic ulcers with bleeding and perforation. So these drugs, these side effects are dose dependent. It increases with the dose. If we are increasing the dose, these side effects will be washed. Okay. Then, if you think that entry-coated or buffered aspirin can eliminate the risk of gastrointestinal side effects, not at all. Use of entry-coated or buffered aspirin in place of plain aspirin does not eliminate the risk of gastrointestinal side effect. Remember that. Okay. Then there is something next where we should contraindicate the contraindications of aspirin, where we should stop the aspirin. Hepatic or renal toxicity are observed with aspirin overdose. The risk of bleeding is increased when we are using with any anticoagulant. Any anticoagulant, warfarin is just an example. We should not use with the anticoagulants. So it can increase the bleeding risk. Okay. Then absolute contraindications. In case of aspirin allergy, which is characterized by bronchospasm. If the patient is presented with bronchospasm, we should not give aspirin at all, because it can land up the patient into trouble of bronchospasm and sudden attack of asthma, or sudden respiratory suppression, or respiratory what we say it, I just forgot the term. So it will land up the patient into the trouble, right? So this is highly we can say prohibited in case of bronchospasm, where the patient has the allergy to aspirin. Okay. So now let's just take up a look on ADP receptor inhibitors. There are three major drugs: clopidogrel, prasugrel, and ticagrelor. Clopidogrel and prasugrel are, and ticagrelor are, we can see as a first generation, second generation, and the current generation. So ticagrelor is a current generation, right? Ticagrelor is a current generation drug, and clopidogrel has we can say the ancient drug we are using for 50 years or more than that. But the thing here is, clopidogrel is most widely used because that is not expensive, and that has the good effect as well. That has the good effect, and but what is benefit by ticagrelor? What are the benefits of ticagrelor? Ticagrelor has overcome the irreversible inhibition. One, ticagrelor has overcome the efficacy part, and ticagrelor has overcome the 15 the binding part. I will tell you how. You know, clopidogrel is only metabolized 15% into the body. When we are taking 75 mg of clopidogrel, only 15 to 20% is metabolized into the body and working. Ticagrelor has overcome that fact, and it is much more efficacious, right? And it has overcome that mechanism of action, and it is having the we can say the time, our efficacy time, or what we say, half life, right? A good half life, because in case of clopidogrel, it is just uh, 30 minutes to 6 hours, but in case of ticagrelor, it is 7 hours to 9 hours, right? And the major part, what is not there with the ticagrelor, because ticagrelor is already a active drug. Clopidogrel and prasugrels are not active drug. They needs to get activated inside the body. These are the prodrugs, but ticagrelor is not a prodrug. Got it? So difference, I'll just go through simply one by one. Clopidogrel and prasugrel are thienopyridine, and ticagrelor is cyclo or pentazolopyridine. And clopidogrel and prasugrel are prodrug. Ticagrelor is already active drug. Mechanism of action: clopidogrel and prasugrel irreversible, ticagrelor reversibly binding with P2Y12 inhibitors. Absorption is actually very good with ticagrelor. That's why we have the more efficacy over clopidogrel and prasugrel. Absorption is like 30 minutes to 1 hour with clopidogrel and prasugrel. Ticagrelor has 1 hour, 1.5 hour to 2.5 hours, right? Metabolism all in hepatic, all in the liver, and elimination is also good with the ticagrelor. Only 26% gets eliminated by urine, and other 58% by feces. Half life is also high with ticagrelor. Dosage forms: clopidogrel and prasugrel has a little flexible dosing, uh, flexible dosing. Like ticagrelor we can give 75 or sometimes 150 mg, but most probably 75 mg, and the loading dose is 300 mg. Loading dose is 300 mg in case of clopidogrel. In case of prasugrel, loading dose is 40 mg or 60 mg, and maintenance dose is 5 to 10 mg in case of prasugrel. Ticagrelor is there is nothing with the loading dose, because daily dose is 180 mg, and we can give 180 mg daily. As even loading dose, we can give two tablets of 90 mg, so it is 180 mg, and then we can maintain 90 mg twice daily, right? Okay, so let's talk about clopidogrel a little bit. Irreversible inhibitor of P2Y12 receptor. Usual dose is 75 mg per day. It's a prodrug. Then ATP, ADP induced platelet aggregation is stopped by clopidogrel. And yes, there is something called clopidogrel resistance, guys. Clopidogrel resistance. Clopidogrel is resistant in many patients. Why? Because this is because of the genetic factors, but ticagrelor has overcome this factor also. This factor also. As we know, I will give you a very basic example, basic funda about resistance. Every human being has different genetic coding. Every human being has different genetic coding. So this is called intervariability. you know Intervariability. When we give drug, we do not know how it will affect in this person, or how it will affect in another person. Even in the same family, even in the same race, or even in the same these things. Now we can actually guess that, okay, in Indo-Americans it will affect same, in Indians it will affect same, in Africo-Americans it will affect same. It will affect same, but no. In there is also something called intervariability. Intervariability comes by the genetic polymorphism. So in case of ticagrelor, resistance, what happens? There is a gene. Called CYP2C19-2. So this is nothing but cytochrome P2C19, and this is an isoenzyme, and this is the second form of cytochrome 2 C19 gene. So in that case, this 2 is allele. Part of gene is called allele. So cytochrome P2C19 2 allele is missed in many races. In many races. So wherever this cytochrome P2C19 2 missed, there are the high chances of clopidogrel resistance. Like, see, 25% of whites, 30% of African Americans, and 50% of Asians carry the loss of function allele. This is the loss of function allele, means this cytochrome P2C19 allele 2 is lost in 50% of Asians, 30% of Americans, and 20% of whites. So this will render them resistant to the clopidogrel. Got it? This will render them resistant to the clopidogrel. But prasugrel or newer P2Y12 inhibitors like ticagrelor may be the better choices over clopidogrel, right? As ticagrelor has overcome all these problems, so we can go for ticagrelor. But what are the side effects? E.g., bleeding or bruising, stomach upset, diarrhea, and constipation may occur with clopidogrel. Okay, so we should avoid clopidogrel with omeprazole. The drugs which inhibits the cytochrome P450, we should avoid the clopidogrel with those drugs. Such drugs like omeprazole, we should not give with omeprazole. Okay, we can so in that case we can refer pantoprazole, esomeprazole, and other drugs, but we should not give with the omeprazole. Let's go to ticagrelor. Yeah, so ticagrelor is a reversible inhibitor of P2Y12, more predictable inhibition of ADP, 90 mg tablet twice we can give. That is the dose, and it is a greater reduction in cardiovascular death, MI, or stroke at 1 year. No differences in rates of major bleeding. So yes, ticagrelor has one disadvantage. It has not overcome the bleeding side effects of bleeding effects much. Of course, it has a good bleeding profile than clopidogrel, but really there is no statistically significant. Clinically yes, but statistically there is no difference, right? And the side effects of ticagrelor are shortness of breath. This is the major side effect, shortness of breath. Some patients with ticagrelor develop the dyspnea, right? And then some patients develop headache, nausea, or maybe nosebleed, epitaxis we call it, right? We should not give the ticagrelor in surgical procedures because it has very much efficacy, in what we say, like in the P2Y12 inhibition, or the ADP inhibition. So in the surgical cases, there are the high chances of active bleeding. So we should not give ticagrelor, right? Now let's talk about the prasugrel a little bit. Prasugrel is also a prodrug that requires metabolic activation in the body. Onset of action is more rapid than clopidogrel, but not more than ticagrelor. Loading dose is 60 mg, and we can give 10 mg per day. Got it? And then there are the chances of if the patient is having a history of cerebrovascular disease, prasugrel is not recommended because there are the high chances of cerebral bleeding with prasugrel. And in prasugrel there is another disadvantage. We need the dose adjustment in renal failure. We need the dose adjustment in case of ticagrelor and prasugrel. In case of ticagrelor and clopidogrel, especially in ticagrelor, we do not need the renal dose adjustment, but in case of prasugrel we need to adjust the dose with prasugrel. So here I'll just show you this chart. This is from the Triton Timmy trial. I will show you, as this is basics, we should not talk about the clinical trials, but it is very good. I should show these clinical trials to you. You should know about the clinical trials. It was the head-to-head comparison between clopidogrel and prasugrel. When we compare the head-to-head outcomes in prasugrel and clopidogrel, we have seen prasugrel shows the very good benefit at the endpoints where like CV death, or recurrence of MI, or recurrence of revascularization. These were the primary endpoints, like cardiovascular death and MI, or recurrent of ischemic events. So prasugrel shows 9.9 and clopidogrel shows 12.1%, which was you can see at p value it is statistically very much significant, and hazard ratio is just 0.81, right? So prasugrel is very much effective than clopidogrel. Let's discuss about clopidogrel versus ticagrelor. Here we can see this is from the Plateau clinical trial. Plateau clinical trial, where they involved around 20,000 people, 20,000 participants. This was given with the aspirin, clopidogrel plus aspirin, and clopidogrel plus Brilinta. Brilinta is the brand name of ticagrelor. Okay, so this chart is taken from the Plateau clinical trial from NEJM, New England Journal of Medical Sciences. NEJM, New England Journal of Medicine. So here we can see all the endpoints: composite of cardiovascular death, MI, or stroke. In that case, this our ticagrelor as is very very high efficacious, and it is showing the less endpoints, only 9.8%, where clopidogrel is showing the composite endpoints 11.7%, and p value, as we can see here, it is just 0.003. That means very much significant in case of comparison between these two drugs. So Plateau trial showed that ticagrelor is very much efficacious and very good over clopidogrel, right? Now let's come to GP2B3A inhibitors. GP2B3A inhibitors are nothing but, of course, a platelet surface integrins. There are about 80,000 copies of these glycoproteins on the platelet surface. You'll be wondered, 80,000 copies of this glycoprotein on the platelet surface, guys. Okay, glycoprotein 2B3A receptors are always inactive and rest in the resting phase on the platelet surface, always on the in the resting phase, right? In the resting phase. So these also need to get activated. How it gets activated? It gets activated by collagen. It gets activated by thrombin. You know, so it as you know, as we can see in this sentence, it undergoes a conformational transitional when platelets are activated by thrombin and collagen and thromboxane A2, that Cox oxygenase product, right? So this transformation endows glycoproteins with the capacity to serve as a receptor for fibrinogen and von Willebrand factors. So how does it work? These are occupied on the surface of platelets. They they invite fibrinogen, they invite von Willebrand factor VWF, and these Willebrand factor and VWF and fibrinogen comes to the platelet surface, and then these everything activates the platelet and invite other platelets to get aggregated, right? So this platelet with these receptors and invited guests means what? Invited guests are like VWF and fibrinogen. Now, this platelet works as a host platelet or the anchor platelet, and they invite other platelets to aggregate, to mingle with them, and to make a plaque. Got it? So that's why we use the drugs to occupy with the glycoprotein surfaces to occupy all the glycoprotein receptors. So fibrinogen and VWF will not come and get aggregated, or will get occupy the surface and invite other platelets. So it stops there. It stops the activation or aggregation of the platelet by inhibiting glycoprotein 2b3a receptors. Got it? So drugs are abciximab, aptifevatide, and tyrofibin. These three drugs are usually given in injectable form. As I told you, the indication in case of MI, in case of procedures, we give when we need the acute suppression of huge huge platelet aggregation. In that case, we need these drugs, right? So this is nothing but about the mechanism of action. As we can see here, this is the resting platelet, and these are the glyco protein 2b3a receptors which are on the surface. Then these are activated by the tissue factors. These platelets are activated by other factors, and now these are inviting thrombin, epinephrine, thromboxane A2, collagen, and other factors to bind to this activated platelet. But when it is not when we are not giving GP2B3A inhibitors or the drugs, this fibrinogen will come and bind here, and you can see as the lower side, this fibrinogen has this binded to this GP2 receptor and inviting other platelets to get bind and making a plaque, right? As you can see, the yellow, these are binding and making a plaque. But when these drugs are occupying these receptors, there is no chance to invite other platelets and get binded or to aggregate, right? So this is that this thing, what mechanism of action. If we tell this, there's nothing much to talk about, because these drugs are not for long term. Side effects are like, you can say, bleeding if we give in the high dose, uh, and these are not used for long term, of course, so we do not have much to talk about GP23 inhibitors, 2b3 inhibitors, right? So guys, thank you for today's class. I think we should be done with the summary of antiplatelet drugs, as aspirin, uh, all indications and all we have talked about. Let's talk about the adverse effect. Aspirin has the increased risk of GI bleed and hemorrhagic stroke, and ADP receptor blockers also have the bleeding adverse effect and abdominal pain or head diarrhea or rest. But in case of ticagrelor, there is dyspnea and bleeding, and prasugrel also can cause intracranial bleeding. That's why we should not give in case of a stroke, right? And GP2BA, 2B3 inhibitors, excessive bleeding, adverse effect, that is main actually. Excessive bleeding or including bleeding from the GI or urinary tract if we give high dose of these things, these drugs. So thank you very much for your patience and listening. I hope this class was informative for you. Let's talk about the questions you asked in the chat. Let's talk about a few questions now. Let me take my iPad and let's discuss the questions. Yeah. Okay. Yes, aspirin is used as prophylactic treatment for the prevention of cardiovascular events or cardiovascular problems, right? Okay, then Ecosprin 75 give to the patients long period in CVA or TIA. Actually, in CVA and TIA, Ecosprin is not recommended as a first line therapy. Clopidogrel is recommended as a first line therapy along with some anticoagulant therapy, maybe. But clopidogrel is recommended, not aspirin, of course. But if they are giving aspirin based on sometimes clopidogrel is resistant to the patient, then aspirin 75 is yes used for long term in the CVA or TIA. Okay, why antiplatelet drugs are only effective in arterial circulation, not in venous circulation? Yes, that is very important question because because when any drug gets gets activated and metabolized, it will reach to it will reach to your cells. It will reach to your where is the question gone? It will reach. I'll answer that. It will reach to your cells, and it will be much late. And in the venous system, when the in the cells when it gets metabolite, na, so when this blood will come back to the vascular system, when it comes to the vascular system, it will not be in the active form. So drug will not be in the active form. That's why they are very very less effective in vascular form. There is nothing like it does not work in they are not activated in vascular phenomenon, but it needs the more active metabolites, or it needs the more active drug. But by the time it comes back to the vascular system, it is not in the active form much. Okay, so where are the lectures? Patient with chest pain has to give an aspirin, an emergency drug, or has to combine with clopidogrel. See, if the patient is having chest pain, let's go for ECG first, because chest pain might be because of some other problems like gastric problems, or maybe because of the musculoskeleton pains. So in that case, we should not directly give aspirin. In that case, we should wait for the ECG or troponin T checkup, and then only we should start the aspirin. But if you really feel that there are the certain chest pains which are not relieving by the platelet pump inhibitors, by pantoprazole or something, or by the normal painkillers, or these pains are not going on the rest. In that case, we should as a prophylactic, we can start aspirin 75 mg. If these chest pains are worsening on walk or worsening with the exercises, we can start this aspirin. Prasugrel should not be given in case of TIA and stroke. Definitely, we should not give. What are the reason why we should not give omeprazole with clopidogrel? Because see, omeprazole inhibits the cytochrome P450 enzyme, and that is the major enzyme which helps clopidogrel into binds to the receptor. So once omeprazole will bind to the receptor, where the clopidogrel will bind and work, it will affect the efficacy of clopidogrel. That's why we should not give with omeprazole. Nitrates will come. So many people are talking about nitrates. Nitrates class is there definitely in upcoming classes. We will talk about nitrates. So let's stick to the antiplatelet drugs right now. Yes, that is very important question. Divya has asked a very important question here. If ticagrelor has high efficiency, then why clopidogrel is only used? Yes, this is a very important topic I will discuss here, guys. See, why we are using ticagrelor over clopidogrel. I mean, sorry, clopidogrel over ticagrelor is still. Ticagrelor tablet is around 100 rupees per day. The expenses of ticagrelor will come around 100 rupees per day. So Indian we can say 75 or 70% Indians are living in the poor families, or in the rural areas, who cannot afford. So the major problem with ticagrelor use and clopidogrel use is the affordability. Ticagrelor is not easily afforded by everyone. So that's why we give only for a month, or we give only for 3 months. The patients who can afford this ticagrelor cost, only we prescribe ticagrelor for long term. Otherwise, we switch the ticagrelor to clopidogrel, because at least patient can take something. In that case, if we are giving ticagrelor forcefully to the patients, in that case, what happens? Patients will not take ticagrelor. He will, he or she will be, medical non-adherent, and then there are the high chances of recurrent of ischemia, or recurrent of other problems, or recurrent of cardiovascular events. So in that case, we prefer at least the patient takes something. Clopidogrel has a good effect, as ticagrelor has overcome, of course, many things, but clopidogrel was ancient drug and widely used in the populations, all kind of populations. So that's why we, only reason of clopidogrel is affordability. Okay, so let's come to a few more comments. Okay, let's come to a few more comments. Okay. How do we know if a patient is resistant to clopidogrel? Very, very nice question. This is, there are some tests called platelet function test. In that case, we check the platelet inhibition, platelet inhibition count, or PIC. So in that case, we need to go for platelet function testing. Okay, that function testing could be, thromboelastography, or that testing should be, aggregometry, aggregometry, which is the gold standard. So they just check the platelet inhibition by the certain drugs. When you are giving drugs, they take your blood and they check the platelet functionality. So these tests called platelet function tests. And normally, if you are not going for platelet function test, how to come how we should come to know that these drugs are resistant? Because when the patient is frequently getting recurrence of MI, frequently, getting recurrence of revascularization or other stroke or some other problems, in that case we can come to know, like, okay, this patient is not is resistant to these drugs. These drugs are not working well, so let's go for platelet function test. There are the indications of platelet function test. Like if the patient was completely cured, or completely cleared with the plaques by PTCA, or by PCI, or by any intervention, there is no block, but patient again got plaque, or patient again got recurrent MI within 3 months or 6 months, then we should think of platelet function test. Okay, let's check some platelet function test, whether our drugs, our clopidogrel or our antiplatelet drugs are working well or not. So in that case, we can go for platelet function testing. These are little expensive, like 1,000 to 2,000 per patient. If we are going for ticagrelor testing, it may cost you around 10,000 in thromboelastography. That cost, that procedure, or that test called TEG testing, thromboelastography. In that case, you may pay high. Sir, you said ticagrelor is reversible and healing process is faster, but wouldn't it cause clot again? Yes, Anne Marie, that's very nice question. Why it will not, cause clot again? Because we are giving the frequent doses of ticagrelor. In that case, we are giving 90 mg twice daily, so it will maintain the work functionality. Why we are giving this? Okay. Does activated protein C activates or degrades platelet factor 5? It activates the platelet factor 5. Sorry, for coagulation factor 5. Mm. In that case, yes. In case of, yeah, I think nicely answered. Are there any CYP2 C19 tests available in India to detect polymorphisms? Yes, there are the genetic tests which are available in India. Definitely, we can go for any genetic testing in India, any good center, anywhere you can test it. What are the things we should monitor while giving antiplatelet drugs? Yes, very important question. We should monitor for the bleeding events. First of all, we should monitor for the bleeding events. Any bleeding, any kind of bleeding, maybe nasal bleeding, epistaxis, maybe bruising, or redness of skin, or maybe bruising of the skin, or while in the toothbrush, while doing the toothbrush in the morning, that is not bruising, but while doing the toothbrush, if your gums bleed, that can be
what we say symbol of or indication for your bleeding. So we should look for the bleeding effects, bleeding side effects of that. We should monitor for bleeding side effects, and then in that case we can go for PT-INR. Not INR actually, but PT or APTT we can check in that case. Okay. After third MI patients die, how you save your patient? Which drug or which treatment you gave? How we will come to know what are the risk factors and what are the other problems the patient had? That we have to check out after case study only. We can come to know. Can we use the aspirin and this type of drugs in case of COVID positive patients? No, no, no. COVID positive patients, if patient is having already some cardiac events or some cardiac problem, then only we should continue the aspirin or antiplatelet drugs. But we should not give as a prophylactic drug in COVID patients. Definitely not recommended by ACC guidelines and ESC guidelines. We should not start in COVID patients. First line treatment of antiplatelet drugs. First line treatment is aspirin plus 1p2 atrial limiter. So that treatment is called DAPT, dual antiplatelet therapy. We should give dual antiplatelet therapy in case of MI, acute ischemia, or after PTCA or after intervention. We should give at least dual antiplatelet therapy for 1 year. Okay, aspirin plus clopidogrel or aspirin plus ticagrelor we should give for at least 1 year. Ticlopidine can cause neutropenia. Yes. No, is clopidogrel given always with aspirin? No, not at all. It's not necessary. In case of stroke, we recommend only clopidogrel for long term. In case of after 1 year of PTCA or after 1 year of acute MI, when the patient underwent any intervention, we should give only one drug after 1 year. But for 1 year, DAPT is recommended. Warfarin is anticoagulant. It will not work on our ADP. It will not work on our Cox. It will not work on our VWF. So that's why we do not give warfarin. Warfarin will work on only on coagulation cascade. Factor 4 calcium is needed for clot. What happens if the patient is suffered from severe hypokalemia? Does their bleeding clot? Does their blood clot is bleeding, sir? No, 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 no. Calcium, yeah, factor 4 is calcium ions, of course, but these are some other factors which are not exactly or not much involved in coagulating cascade. Factor 4 is not much involved. These are involved in clot formation, but not much. So it is very less. There are very less chances in case of hypocalcemia. If the patient suffers with hypocalcemia, there is very less chances of this clotting or bleeding. Can we give antiplatelets with factor XA inhibitors? What are factor XA inhibitors, by the way? Can we give antiplatelet drugs with factor XA inhibitors? Yes, we can give antiplatelet drugs, but there are the high chances of bleedings. Factor XA inhibitors are nothing but anticoagulants. Okay, factor XA are nothing but anticoagulants. But when we give aspirin with the anticoagulants, there are the high chances of bleeding. So we should avoid in that case. But when recommended, sometimes we can give like a single antiplatelet drug plus any anticoagulant drug. Single antiplatelet, but not dual antiplatelet therapy. Dual antiplatelet therapy with the anticoagulation is not at all recommended. Any other contraindication other than omeprazole? Clopidogrel has some other problems with other drugs also, like phenytoin, like other antipsychotic, antidepressant drugs, and even with a few antibiotics. What are the drug of choice if patient undergone surgery for coronary blood vessel? After bypass surgery, clopidogrel is recommended for long term, but at least for first 1 year, they first 6 months to 1 year they use dual antiplatelet therapy, but it's not necessary. No, ticagrelor and anticoagulant combination is not safe because ticagrelor has it will cause high bleeding risk. It can create high bleeding risk in the CVS disease or stroke patients. Okay, guys, so I think there are no more questions, or you can post your questions and we will clarify later. Okay, thank you very much for the class, and thank you very much for attending the class. Take care, guys. Good night. Bye. You can post your questions. I will answer later. Okay, bye. Take care.